Hello, everybody, and welcome to the Hughes Clues Respiratory Pearls. I've done this recording because of some concepts that were missed on exam one, and so I felt like there needed some additional explanation. This is kind of a complex concepts or more advanced, and these concepts are usually on the test, which is why I wanted to do this recording. There's usually one question on each of the topics that I'm going to cover, so it doesn't really have a lot of weight. But if you're the type of student that wants to make a really, really good grade, then on your exam, then this is the recording for you. So one of the things that Dr. Reed really likes is how about ventilator management in the patient with COPD. So this is a patient who's got a known history of either emphysema or chronic bronchitis, and would you manage that COPD patient differently from a patient who does not have a history of COPD? And so the first thing you really have to consider is what does the ABG look like for a normal COPD patient? And you would realize that, well, likely they have a normal pH because they've had a chronic illness and so their body is able to compensate on a daily basis. And because COP, the disease in itself, causes a retention of of CO2, of carbon dioxide, you would expect that on a normal day, on a good day for a COPD patient, they would have an elevated CO2, and as because of compensation, then the kidneys would make more or hold on to bicarb. Their oxygen levels should be in the normalish range, and normal for critical care course is really the O2 sat of 90%, whether it's SpO2 or SaO2. And then the PaO2, Dr. Reed has kind of set a bar that as long as it's above 60, it's in the okay margin, even though I know that the PaO2, the normal, is 80. Now, these values, just as an aside, don't use them when you do ATI and NCLEX because they're absolutely too low for the average patient. But in critical care, I basically throw a parade when my patient has an oxygen saturation of 90%. These people are ill. Therefore, because this ABG that's sitting in front of you is normal, well, we would say that, okay, so the pulmonologist would not expect to have a CO2 as normal. And so what I mean is when you have a pH that falls anywhere in the normal range, even though the rest of the ABG has abnormal ranges and so therefore cannot be described as a normal ABG, we would say that anytime the pH falls in the compensated acidosis range, that means anywhere between 735 and 7.40. So it should fall between either 736, 737, 738, or 739. And as long as the pH falls within the normal range, then likely that COPD patient is doing okay. Again, the O2 sat should be 90% or above, and the PaO2 should be 60 or above. Of course, the higher the better, but remember that O2 is also a problem for a COPD patient. They chronically have elevated CO2, and because of their long-standing retention of CO2, the O2 is usually somewhat diminished also because of the illness. If this doesn't make sense to you, then just email me. Again, as long as that patient of COPD has a compensated acidosis, in other words, the pH is falling in the normal range, somewhere between 3.5 and 7.40, then that patient is considered doing okay. The next respiratory pearl that I have is essentially about the ventilator alarms. There are there is a question usually about the ventilator alarm. So when we think about ventilation, we know that how easy it is to blow air into lungs depends on the patient's stretchiness of their lungs. In other words, the compliance of the lung or how resistant that lung is. And if you have a patient who has a chronic respiratory disease, no matter what it is, or even if they're just older, their lungs are going to be less stretchy. They're going to be less compliant. They're going to be more resistant to the pushing in of air. And whenever they're first put on a ventilator, well, the respiratory therapist will assess that compliance or that stressiness, and then they will set an alarm for how resistant those lungs are. And so that becomes that patient's normal. So let's pretend that we have a COPD patient. Their lungs are somewhat stiff. They're less compliant than a 20-year-old. And so when the respiratory therapist first assessed them and put them on a ventilator, they noticed that it took a moderate amount of force for the ventilator to push in air. So let's say that the peak pressure, that just means how much force has to go in, is somewhere in the 30 range. And so the respiratory therapist would set that alarm either at a little bit higher, so around 40, or say 20. They usually set 10 above or 10 below. These may vary depending on the therapist. So that means that if the high pressure alarm is going off, then that means that instead of the normal 30 amount of pressure that the ventilator has to exert to get air in the lungs, it's having to use a lot more force to push in air. And if it's a greater, really great number, then it's going to keep alarming off. So what's the big deal with this? Well, the big deal is that the ventilator is not able to deliver air. So your patient's not being ventilated. Now, you, the nurse, of course, as soon as the alarm constantly or consistently goes off, one here and there is not going to be that big a deal. But if the alarm is continually sounding 3, 4, 5 times, then you know that number one, the patient's not getting air by the ventilator, and two, there's got to be a problem. So you need to assess, what is that problem? Well, what would make there be more resistance or an inability of the ventilator to push in air? Well, there's something wrong with, there's some kind of blockage that's in that endotracheal tube. Now, it could be just as simple as the patient's biting on the tube, or you've turned the patient to the side and the tube is kinked, or it could be that there's an obstruction such as mucus, or which is snot, or the patient is coughing. If the patient coughs, they're pushing out against the ventilator as the ventilator's trying to blow air in. So these are some things that are fairly common that would cause an increased or the high pressure alarm to go off. One of the more concerning things would be if the patient is developing ARDS, because as we talked about earlier in this presentation, that ARDS will cause a stiffening or even more resistance to occur. So if the pressure alarm keeps going off consistently throughout the day, then you need to listen to the patient's lungs. Are there rails or crackles that weren't there before? Or is there absent breath sounds on one side, which might indicate to you that there's some kind of barotrauma and pneumothorax? So if this doesn't make sense to you, how a pneumothorax could cause the high pressure alarm to go off, well, then email me. What I just want you to get, because I know your brains are pretty full at this point, is that anything that causes an obstruction in the endotracheal tube or stiffening of the lungs is going to cause an increase in resistance to the flow of air being shoved in by the ventilator. So the most common things are going to be kinks, patient coughing, patient biting on the tube, and probably the most frequent one is that there's secretions or snot within the lungs. Well, what does it indicate if the opposite occurs, if the low pressure alarm is going off? Well, that means that there's a leak somewhere, and it can be anywhere along the system. It could be a disconnection here between the tubing and the ventilator itself. It could be a disconnection here where the tubing is not connected to the endotracheal tube. It could be a leak in the balloon cuff of the endotracheal tube. So essentially, a low pressure alarm means there's a leak somewhere. And so you've got to assess that. And you don't feel like you always have to do this on your own. If you're a brand new graduate, you can get the respiratory therapist in to kind of help you problem solve until you get some experience with this. Now, another respiratory pearl that I want to identify is that Dr. Reed, in her Jeopardy, which is extremely important for you to listen to or look at, Dr. Reed will identify that the manifestations or the signs and symptoms that lead you, the nurse, to suspect that your patient is going into ARDS or has ARDS are this laundry list. So the progressive refractory hypoxemia, VQ mismatch, tachypnea, respiratory alkalosis, increased peak pressures, and altered LOC. So let's go through each one of those. If you're an inquiring mind and you're like, well, this doesn't sound something that makes sense to me, so I want to just do a very brief description of each of the problems. Progressive hypoxemia, we have talked about, but it's very important that you get that. That if the patient has a low PO2, or oxygen saturation, whatever the case may be, and then you get an order from the physician that you want to increase the oxygen delivery, the FiO2, that's supplemental oxygen. So you've taken it up to 40 or 50 or even 100%, but the patient still is not increasing or improving their oxygen status in their blood. Well, that's known as refractory hypoxemia. So not a decrease or not an increase in the blood oxygen level despite the fact that you're increasing the supplemental oxygen. VQ mismatch, this is something that you learned in patho that you've probably forgotten. Recall that there are two parts to inhalation. One is that you breathe in air, and that's just the taking in of oxygen. And then the other part is the perfusion. Once the air or the O2 gets into the alveoli, where there must be blood that must pass through or come near in the capillary systems to the alveoli, and there must be a transfer of O2 into the capillary. And then, of course, the CO2 will go the opposite direction and out. But you have to remember that if for some reason a patient comes in that they're short of breath, well, physicians are going to go, well, I don't know where the problem is. It could be in the fact that they're not getting enough O2 in, or it could be the fact that there's not enough blood. And because a lot of the respiratory system is related to the physics, which was not a topic I really got, it becomes a ratio, and it's called the VQ ratio. In other words, there is a very steady state that you and I inhale 4 liters of air, and that after we inhale 4 liters of air, 5 liters of blood will go cruising through the capillary system, and that's how your blood or your O2, the gases, are moved around in and out. And so therefore it becomes a mathematical ratios, so it's 0.8. So if there's any kind of abnormal VQ, that means it falls either in less than 0.8 or greater than 0.8. And this will help the physician pinpoint the problem from a mathematical physics perspective. So this is a lot of information. All you need to know is that there is a VQ mismatch in ARDS. Tachypnea and respiratory alkalosis kind of come together. Let's think about problems such as ARDS, pneumonia, pulmonary embolus. All those things, all those problems cause a lack of O2 in the blood. In other words, hypoxemia. And as the blood is cruising around in the body, especially in the brain is going, yo, there's not a whole lot of oxygen here. We need more oxygen. So the brain will actually direct the lungs to breathe faster. The lungs don't control the rate or depth. It's the brain that does that. The brain tells the lungs what to do. And so when there's a low oxygen state, the brain will say, breathe faster. And so this individual will have tachypnea or rapid respiratory rate. Now, you know that when a patient breathes out, yes, they're breathing in and they're supposed to be breathing in more O2, but remember, with pneumonia, pulmonary embolus, and ARDS, that's the problem. They can't bring in more O2. But on the flip side of that, as the patient breathes faster, it's not helping with their O2 state, but it is removing a lot of CO2. And that will cause the patient to go in a respiratory alkalosis state. So truly, if your patient has respiratory alkalosis, then you need to be concerned, because this is usually one of the initial signs that there's an oxygenation problem. It can be. So this is something you need to think about, and not just thinking in a kind of a judgmental way that we all do, myself included, that the patient's a freakazoid and that they're just being dramatic. That respiratory rate that's rapid could be a cause or caused by a low O2 state, or the early part of a low O2 state. Altered levels of consciousness or restlessness, you guys know this is probably something from Junior 1. That hypoxemia, beginning stages of hypoxemia, can cause a patient to feel bad, to feel very restless. They get very anxious. And if it is allowed to go on long enough, then the level of consciousness can change. Now, with initial signs of ARDS, we kind of talked about this, so I'm not really going to go over this much, but just know that that peak pressure will increase. The alarm, high pressure alarm, will sound because as ARDS is developing, then the patient will have a stiffening or decreased compliance, more resistance, and there will be an inability or a decreased ability for that ventilator to be able to shove in air. And so, of course, the peak pressure goes up, which just really means that the high pressure alarm goes off. So you have to listen. Is the patient showing those signs of refractory hypoxemia and restlessness and rapid respiratory rate? These are all things, when you put them together like a puzzle, they come up with the answer of ARDS. And remember that you should have a high index of suspicion that they will develop ARDS when the patient comes in with problems such as sepsis or pneumonia or multiple blood transfusions after a traumatic injury, and pancreatitis. These inflammatory kind of problems sets them up for ARDS. Again, all the words are there. Just pause the recording and listen because I know it's a lot of information. Okay, last topic on the respiratory pearls. There is usually one question on exams 1 and 2 on this topic. And it's kind of a difficult concept to wrap your head around. So what I do is I've got this picture here. Of course, your heart, it's one heart, but we do divide it out into the left side and the right side. And I have the left side colored red because that's where oxygen is moved around from. And think of this as a UPS truck. If the UPS truck is like your ventricle, what is the UPS truck carrying? Well, it's carrying packages of oxygen. And as the depot, the left ventricle, shoves out the UPS truck with 100 packages, as the UPS truck makes its way down, down, down through the arterial system, it will drop off little oxygen packages to the cells. And so that's what's known as the O2 delivery. So we have this UPS truck with a lot of O2 packages, and it drops off oxygen at the tissue level, and then as it makes its way back to the depot, it comes in on the right side of the heart, and that's where we can measure the oxygen saturation of venous blood. So that's what SvO2 is. That is the oxygen saturation of venous blood. So note that if your patient had 100% oxygen saturation at the start, when it was full of oxygen, when the UPS truck was full of oxygen, by the time that truck made its way all the way around, down through the body and back to the right side of the heart, only 20 to 25% of those packages, of those O2 packages, would have been delivered, which is why you can hold your breath, because as each pass around the body, we do not use all the oxygen that is available. The cells don't take more than what they need. They get what they need, and then that's it. And then so the excess is returned back to the right side of the heart, where the truck fills up again with oxygen from the lungs and then makes its way back round and round. So that tells us a lot about the cells. How are things going at the cellular level? If we see that the patient started out with an oxygen saturation that we can measure from ABGs, if the oxygen saturation was at 100, and then we can draw blood and measure the venous saturation, and we can see that the cells only extracted or took or grabbed 20 to 25% of the O2, well, we know that at the tissue level, the tissues are doing okay. So what would make this venous saturation dramatically go down? And so these are the things that increase, or things that increase tissue metabolism, or the metabolic needs of the tissue, is when the tissue, when it needs more O2, it's going to grab more off that truck. So look at the list here. If the patient had an infection, well, you know that's going to increase the metabolic rate of the tissues, and those tissues are going to grab more oxygen off that truck, and the venous saturation is going to go down. And if the patient's in pain or they're stressed or there's a lack of sleep or they have hyperthyroidism, any of those things can cause the need for more oxygen at the tissue level. Now, let's talk about this one. Well, what about reduced cardiac output? So let's go back to our UPS truck analogy. If the cardiac output is low, that means that instead of having a UPS truck that makes its round every day, now cardiac output goes down. Maybe that UPS truck can only make it every other day. And cells are really, really smart. They get this. And so what they will do is, because there is not a frequent delivery, well, then those cells are going to grab more when they can. So they're going to grab a whole lot more off, so the oxygen saturation in the venous system will go dramatically down. It will be very low. Like I said, I had a patient once who had a horrible cardiac output, bad heart failure. The oxygen saturation was at 40%. Their arterial saturation was 98%. They were getting it into the blood fine. But because the cardiac output was so bad, then the cells were extracting or taking a lot more off that truck each time it passed, because it wasn't coming by very often, and the venous saturation is 40%. So this again tells you what's happening at the cellular level. Now, there's some problems that will cause or not allow, some illnesses that will not allow the cells to grab any O2. And so you're going to have O2 that's high on the arterial side and O2 that's equally high on the venous side. And this is a bad, bad thing. We want the oxygen to be dropped off. We want the cells to get oxygen. That's how they work. And when we see this level here, the venous saturation at 100%, well, then we know that the cells are really in big trouble and having to do anaerobic metabolism. I hope this has been helpful. I hope it's made sense. Please contact me if it's not been helpful or if you have more questions.